Imagine breaking your arm, right? But instead of the doctor just, putting it in a cast, they hand you a menu.
Oh, wow, like a restaurant menu.
Yeah, exactly. And option A might heal the bone, but it leaves you with severe chronic pain. Option B involves intentionally burning the tissue with a laser.
Sounds awful.
Right. And option C is injecting your own blood back into your body for like $1,700 out of pocket.
Which is just wild to think about.
It is. But welcome to the murky, highly preference-sensitive world of women's intimate health. We are looking at conditions that happen after menopause or childbirth, where, honestly, a diagnostic X-ray machine is basically useless.
Yeah, it's the absolute definition of diagnostic muddy waters. I mean, are talking about conditions that affect millions of women, dictate their daily routines, and yet
They're totally ignored.
completely, historically under-discussed, chronically under-researched, and now they're becoming incredibly heavily commercialized.
Okay, let's unpack this. Our mission for you today is to explore how the medical field is treating two major conditions: Genitourinary Syndrome of Menopause, or GSM, and stress urinary incontinence, or SUI.
And we really have a massive stack of sources to cross-reference today.
We do. We've got strict clinical guidelines from the American Urological Association, methodical treatment pathways from NHS Scotland, a major safety overview from NICE in the UK.
Not to mention those incredibly detailed randomized trial protocols from the University of Iowa.
Right. And to cap it off, the slick marketing materials from high-end private clinics in London.
The contrast between those sources is just jarring. I mean, to really grasp the tension between the slow pace of clinical science and, the aggressive nature of commercial medicine, we have to look at the sheer scale of the problem.
Which is huge.
It's massive. Before any patient is desperately searching for a private laser clinic online, they're usually suffering in complete silence for years. Take Genitourinary Syndrome of Menopause, or GSM. According to the 2025 AUA guideline, anywhere from 27% to 84% of postmenopausal women experience GSM symptoms.
Wait, 84%?
Up to 84%, yeah.
To put that in perspective for you listening, if you are sitting in a coffee shop right now, almost every single postmenopausal woman in that room is likely dealing with this, yet no one is talking about it.
It really is a hidden epidemic.
Yeah.
And the symptoms are, they're profoundly disruptive. GSM is caused by a significant drop in estrogen, which leads to a thinning of the tissues.
Right.
So patients experience severe vaginal dryness, burning irritation, painful intercourse. And structurally, because the tissues supporting the pelvic organs are weakening, GSM frequently overlaps with lower urinary tract issues.
Mostly stress urinary incontinence, right?
Exactly. SUI.
SUI is that involuntary leakage of urine when you exert yourself. Like you lift a heavy box, you laugh at a joke, you cough, you sneeze, and you leak.
And it might sound like a minor inconvenience to someone who has never experienced it.
But the source literature makes it clear how completely this dictates a patient's quality of life. Women stop exercising, they avoid social situations.
They map out the bathrooms in every single building they enter.
Yes. So when a patient finally reaches a breaking point and goes to their doctor, what is the protocol?
Well, the NHS Scotland pathway for SUI and overactive bladder is highly methodical. It starts at the absolute baseline with conservative management.
Which means what exactly?
They advise you on managing your fluid intake, they put you through strict bladder retraining schedules, and they prescribe months of targeted pelvic floor exercises.
But if that conservative approach fails, the pathway dictates moving to medications. You start seeing drugs like tolterodine or mirabegron.
Right, because the bladder is essentially a balloon made of muscle.
Yeah, and these medications work by trying to force that overactive bladder muscle to relax so it can hold more volume without randomly spasming.
But they often come with frustrating side effects. I'm talking severe dry mouth or constipation.
So when the pills fail or the side effects become intolerable, the patient is staring down the barrel of surgery. And this is where the standard playbook gets genuinely terrifying.
It really does. The clinical trial protocols we reviewed detail how traditional surgeries, like implanting mid-urethral slings or synthetic mesh, are highly effective at physically propping up the urethra to stop the leaking. But they carry an estimated complication rate of up to 6%.
A 6% chance of complications for a quality-of-life surgery is massive, especially when you look at what those complications actually are.
We're talking about severe hemorrhage, accidental injury to nearby organs, and chronic, debilitating pelvic pain.
And the most notorious complication is mesh exposure, right?
Yes. That's where the body's immune system recognizes the synthetic mesh as a foreign invader. It creates chronic inflammation.
Oh, that sounds awful.
It is. And over time, the abrasive synthetic material literally rubs and erodes right through the thin vaginal wall.
That is horrifying. And that potential for catastrophic surgical failure is precisely why the 2025 American Urological Association guideline leans so heavily into something they call the SHARE approach.
Right, for shared decision-making. Because the medical community officially categorizes GSM and SUI as preference-sensitive conditions.
I find that term fascinating. Preference sensitive basically acknowledges that unlike a clear-cut emergency, like if your appendix is bursting, the only right answer is to take it out.
Right, you don't debate an appendix.
Exactly. But these conditions have multiple options, and none of them are perfect.
So the patient's personal goals and risk tolerance become the deciding factor. The clinician has to ask, are you willing to take a daily medication that makes your mouth feel like cotton?
Or are you willing to undergo a surgery that might cure your incontinence but carries a documented risk of leaving you in chronic pain?
It's a tough call. And the guideline also uniquely stresses the necessity of trauma-informed care.
Which makes complete sense structurally. If a patient has a history of physical or psychological trauma, particularly intimate partner violence, their body often physically holds that tension.
Exactly. Their pelvic floor muscles might be constantly guarding or hypertonic.
The AUA is urging clinicians to recognize that the exam room itself, like the physical vulnerability of being in stirrups, the invasive nature of the exams, can be a biomechanical and psychological minefield.
And that directly impacts the success of the treatment.
So, looking at these standard options, the months of daily exercises, the muscle-relaxing pills, the surgeries with a known 6% risk of severe complications, it paints a grim picture.
It's really bleak.
It feels exactly like shopping for a used car where every single model on the lot has a documented factory defect. You're basically wandering the lot trying to figure out which catastrophic failure you are most willing to live with.
That is a perfect analogy.
So if the surgical mesh is essentially a ticking clock for some patients, it completely makes sense why women are desperate for a non-surgical magic bullet.
And the medical market knows this, which brings lasers into the exam room.
Ah, yes. Lasers.
The pivot to transvaginal lasers is driven entirely by that fear of surgical complications. I mean, the idea of a non-invasive, quick outpatient procedure sounds like a miraculous alternative.
How does it actually work?
Well, devices using CO2 or EAG lasers are inserted into the vaginal canal, delivering targeted energy into the mucosal layer.
Wait, so we're essentially causing a controlled burn inside the body to force it to panic and heal itself.
What's fascinating here is that the clinical literature is very specific about this.
Yeah.
Yes, the laser causes a controlled thermal injury.
But shining a light inside the body, I mean, it's not a soothing, therapeutic light.
No, not at all. The thermal energy heats the water inside the tissue, literally vaporizing microscopic columns of cells. We are talking about intentionally causing a burn.
That sounds intense. Is the potential trade-off really worth avoiding the risks of traditional mesh surgery?
Well, think about how you build muscle at the gym. You lift heavy weights to create microscopic tears in the muscle fibers, and your body repairs them to be thicker and stronger.
Okay, I follow that.
The transvaginal laser uses that same biological logic. By intentionally inflicting thermal damage, you trigger the body's panic response. The surrounding tissue rushes to patch these microscopic holes.
Stimulating a massive production of new collagen and elastin.
Exactly. The theoretical result is a thicker, more robust vaginal wall that provides better physical support to the urethra and bladder above it.
I understand the mechanism, but I still have to push back on the premise. We are talking about inflicting a controlled burn inside one of the most highly innervated, sensitive parts of the human body, just hoping the tissue repairs itself the way we want it to.
And yet the data suggests that for a specific subset of women, that thermal gamble actually pays off.
What does the data say?
The National Institute for Health and Care Excellence in the UK, or SE, compiled extensive trial data. For example, the Blaganji randomized trial out of Slovenia followed 114 premenopausal women.
Okay.
At the 3-month mark, 21% of the patients who received the actual laser injury were completely dry. They scored a 0 on the incontinence scale.
And the placebo group?
In the sham group, where the device was inserted but the laser never actually fired, only 4% were dry.
There is also that Okiwi study from Japan, right? The one that used a 1-hour pad test.
Yes, and that isn't a subjective questionnaire. It is an objective physical measurement. They literally weigh a sanitary pad before and after an hour of intense physical activity to see exactly how much urine escaped.
And the results were wild. The women in the laser group started with an average leakage of 34 grams. After treatment, that dropped to just 2 grams.
Going from 34 grams of leakage to 2 grams means you stop planning your life around bathroom access and start living normally again.
Those numbers are undeniably compelling. But NICE-E provides a crucial reality check, don't they?
They do. They explicitly warn that the overall quality of evidence for transvaginal lasers is highly limited. The sample sizes are generally small. The trials lack long-term follow-up to see if the collagen holds up over years.
And researchers often mix different types of incontinence together, which really muddies the data.
Exactly. But the real reason NICE urges caution isn't just about the messy data. It's about the catastrophic adverse events.
Right, because while many clinics advertise minor side effects like temporary discharge, the clinical literature documents some harrowing realities of what happens when a controlled burn goes wrong.
Very wrong.
Yeah.
Take the 36-year-old woman in Taiwan. She underwent a laser treatment for her SUI. 5 days later, she presented at the hospital with total, uncontrollable urinary incontinence.
Because the laser went too deep, right?
Yes. The laser had penetrated too deeply, destroying the tissue barrier entirely. She developed a vesicovaginal fistula.
Which is literally a burned hole directly connecting her bladder to her vagina.
Right. She had to wear a catheter for 2 weeks just to let the internal wound heal.
And the risk of severe scarring is equally alarming. There was that case report from Spain involving a 48-year-old woman.
Yeah, a month after her second laser session, she began experiencing intense pelvic pain, and her menstrual periods completely stopped.
When specialists examined her 3 months later, they discovered her vaginal canal had severely scarred and shrunk to a depth of just 2 to 3 centimeters.
Because the body panicked from the burn and overhealed, it created a complete transverse vaginal septum.
It essentially built a solid wall of thick scar tissue that entirely blocked the canal. And because her canal is blocked, her menstrual blood had nowhere to go.
It became trapped inside her body, pooling over months to form a massive, painful, cyst-like mass called a hematocolpos.
The physical reality for this patient was horrific. She required multiple, complex reconstructive surgeries just to cut away the scar tissue and widen the canal again. Even 2.5 years later, she was still managing chronic pelvic pain.
Which brings us back to the preference-sensitive dilemma. Are you willing to trade the known 6% risk of a synthetic mesh eroding through your tissue for the unknown risk of a laser burning a hole in your bladder or scarring your canal shut?
The medical establishment is deeply divided on this. Clinical guidelines insist lasers should primarily remain in rigorous research settings,
while private clinics aggressively promote them as safe lunchtime procedures.
But if the idea of a thermal burn sounds too barbaric, the market has anticipated that fear. What if we could bypass the destruction entirely? No scalpels, no synthetic mesh, no lasers.
What if we could just extract your body's own natural healing serum and inject it precisely where you need it?
This represents the major shift from thermal intervention to pure regenerative biology. We are talking about platelet-rich plasma, commonly known as PRP.
Right. Let's break down the actual process of PRP. You sit in a chair, and a clinician draws a small vial of your blood, exactly like a routine physical.
Okay.
They take that vial and place it into a centrifuge. The machine spins the blood at incredibly high speeds, using centrifugal force to push the heavier red blood cells to the bottom,
leaving a golden layer of plasma floating at the top. And this plasma is hyper-concentrated with your own platelets.
Exactly. Platelets are the body's biological first responders. When you get a cut, they rush to the site to clot the blood. But when you extract them, concentrate them, and inject them back into a targeted area like the anterior vaginal wall,
they act like a biological distress flare.
They release a massive, complex cascade of growth factors into the tissue. The sources mention platelet-derived growth factor, transforming growth factor beta, and vascular endothelial growth factor.
Instead of just listing these like a textbook, think of vascular endothelial growth factor, or VEGF, not as a building material, but as a project manager.
I like that.
When VEGF hits the tissue, it calls in the biological bulldozers to lay down new infrastructure. It promotes angiogenesis, which is the literal creation of new microscopic blood vessels.
Yeah. The biological hypothesis is elegant. By flooding the weakened tissue around the urethra with these concentrated growth factors, you stimulate cell proliferation,
dramatically improve blood supply, and rebuild the structural integrity of the pelvic floor without ever having to cut or burn anything.
It sounds absolutely flawless. It's your own blood, so the risk of an allergic reaction or foreign body rejection is virtually zero.
And because the theory sounds so perfect, the commercial medical market has exploded. But the gap between the commercial marketing of PRP and the actual clinical science is vast.
If we connect this to the bigger picture, let's look at the Dr. SW clinics based in London. They offer a trademark PRP treatment called the O-shot.
Their marketing approach does not treat this like a somber medical intervention. It is framed as a glamorous, comprehensive lifestyle upgrade.
Right, they advertise this single injection for stress urinary incontinence, orgasmic disorder, painful sex, and even chronic skin conditions like lichen sclerosis.
Which is a condition that causes severe thinning and white patches on the genital skin.
The language they use targets vulnerability with the promise of immediate empowerment. They ask their prospective patients, is lifeless lovemaking getting you down? Let the O-shot revive your inner sexy goddess.
They promise stronger orgasms, a return to work the same day, and a cure for incontinence. And they are charging 1,300 British pounds per session.
That is nearly $1,700 out of pocket for one injection of your own spun-down blood. And they almost always recommend multiple sessions.
While patients are swiping their credit cards in London, clinical scientists in the United States are practically pulling their hair out trying to figure out if it actually works.
Yeah, over at the University of Iowa, researchers are currently running a meticulously designed clinical trial on this exact procedure. And their methodology exposes just how little we actually know.
The Iowa trial protocol is brilliant. They are bringing women in, drawing their blood, and spinning it down in the centrifuge. But here's the catch. They then randomly inject the patient with either 5 milliliters of their own golden PRP or 5 milliliters of a placebo saline solution.
And the blinding is so strict that neither the patient nor the examining doctor knows which syringe is being used.
They have to go through the immense logistical trouble of drawing blood from the placebo group just to throw the PRP away and inject saline purely to isolate the placebo effect.
The Iowa researchers explicitly state there is an urgent need for high-quality evidence because the current data is completely insufficient to prove that PRP cures SUI.
And the most fascinating part of the Iowa trial is what they are trying to measure. When you inject 5 milliliters of fluid into the tissue surrounding the urethra, that liquid takes up physical space.
Right.
So the scientists are trying to figure out if the patient's incontinence is improving because the magical growth factors are actually remodeling the tissue.
Or if injecting 5 milliliters of any liquid is simply squishing the urethra shut from the outside.
Exactly. Creating a temporary mechanical seal that will just dissolve in a few days.
It perfectly highlights the tension. Commercial clinics are selling certainty, while clinical science is still testing basic mechanics.
I look at this dynamic and I see an indie band that just went mainstream. The private clinics are standing out front, aggressively selling incredibly expensive VIP tickets to the show based on a cool demo tape.
And the clinical scientists?
They're still stuck in the back room, frantically trying to figure out if the band actually knows how to play their instruments.
That's spot on. And to fully understand how cautious the regulatory bodies are about this indie band, we can look at how NICE handles PRP in a totally different part of the body.
Oh, right.
NICE published an interventional procedures document regarding PRP injections for knee osteoarthritis.
It is the exact same biological concept. You spin down the platelets and inject them to heal worn-out cartilage in the knee.
Yet NICE concludes that while PRP in the knee raises no major safety concerns, the evidence for its efficacy is so limited in quality that it mandates special arrangements.
Meaning doctors can't just casually offer it.
Exactly. They have to undergo strict clinical governance, obtain specialized consent, and submit to continuous clinical audits.
The irony is staggering. For a knee joint, the government health authorities are demanding intense audits and special governance because they aren't convinced the growth factors actually work.
But for the exact same biological fluid injected into the vaginal wall, an incredibly sensitive, complex area,
private clinics are completely unbothered by clinical governance, freely marketing it as a $1,700 cure-all for everything from incontinence to sexual dysfunction.
This is the regulatory gray area of regenerative medicine in a nutshell. Because the clinician is using the patient's own blood, it doesn't face the same grueling multi-year hurdles that the FDA or the European Medicines Agency would force on a newly manufactured pharmaceutical drug.
This loophole allows commercial clinics to leapfrog the slow, methodical pace of clinical trials and take the promise of the treatment directly to a desperate consumer.
It really does.
So what does this all mean? We have covered a massive amount of ground today. We started by looking at the silent, overwhelming prevalence of Genitourinary Syndrome of Menopause and stress urinary incontinence.
We walked through the standard NHS playbook, navigating the known defect waters of muscle-relaxing pills and synthetic surgical mesh.
We examined the double-edged sword of transvaginal lasers. The incredible promise of dropping from 34 grams of leakage down to 2 weighed against the physical nightmare of a severely scarred, blocked vaginal canal.
And finally, we explored the commercial gold rush of PRP regenerative therapy, where glossy marketing has vastly outpaced the rigorous, placebo-controlled data.
The connecting thread through all of these sources is the absolute necessity of critical thinking. When a vulnerable, heavily stigmatized medical condition meets aggressive, out-of-pocket marketing, the patient is caught directly in the crossfire.
The AUA guidelines' share approach to decision-making is brilliant in theory, but it fundamentally requires the patient to have access to unbiased clinical truths, not just sales brochures.
This deep dive is entirely about empowering you to be the central active figure in that exam room. You aren't just a passive recipient of whatever treatment is currently trending. You have to be the lead investigator of your own health.
Because the desperation for a cure, the simple desire to lift a box without leaking, or to enjoy intimacy without burning pain, is an incredibly powerful motivator.
Right.
And while regenerative biology and thermal lasers hold genuine, exciting potential, they are not without real physical risk, and they are certainly not a guaranteed magic bullet.
Which leaves us with a final thought to ponder today. If minimally invasive treatments like burning tissue to force collagen production or injecting your own blood to summon growth factors currently exist in this strange gray area between an unproven experimental trial and a highly lucrative private clinic offering, how will this change the way you negotiate your own health care?
It's a huge question.
When the noble goal of shared decision-making collides with the reality of aggressive medical marketing, who really holds the ultimate power in the exam room? Is it the slow, methodical clinical science? Is it the glossy, empowering sales pitch? Or is it you, the patient? If you're standing on that used car lot and every single option has a hidden cost, whose word do you trust before you drive off? Think about it. We'll see you next time on The Deep Dive.